A patient stands at a United States pharmacy counter and hears one number, copay. Two other numbers never reach that counter. One is the manufacturer's published list price. The other is the net amount a health plan will record after a rebate returns on a later ledger. Between those figures sits an intermediary most patients cannot name. The health plan hired that intermediary to control prescription costs. Pharmacy benefit managers process claims, build pharmacy networks, and bargain with drug makers. Employers, commercial insurers, Medicare Advantage organizations, and Medicaid managed care plans do not negotiate every tablet themselves. The hire looks clean. A specialist who lives inside the price file should, in theory, hold spending down. The same specialist can be paid on other terms. A manufacturer rebate can land at the PBM before it is shared with a plan, or not shared at all with the person at the counter. A PBM can bill a plan one reimbursement and pay a pharmacy a lower one, keeping the difference. A PBM can share a corporate roof with a mail-order pharmacy or a specialty pharmacy, and network design can route expensive fills through that roof.
No conspiracy is required. A contract is enough. The claim adjudicates in seconds. The rebate may take a quarter. The patient has already driven home. Federal Trade Commission staff reported that in 2023, the 6 largest United States pharmacy benefit managers handled more than 90% of prescriptions. The middle of the chain is the chain. This is not a story about a single brand. It is a story about a payment chain. Here is the contradiction, held inside its own fence. Intermediaries hired to control prescription costs can also profit from opaque rebates, spread pricing, and vertically integrated pharmacies. That fact does not license a larger claim. It does not prove that every PBM contract raises every patient's price. It does prove that a small group of administrators can influence which medicines millions of Americans receive, which pharmacies fill them, and how costs are distributed. The bottle leaves the shelf. The money takes another road.
Most Americans meet a prescription as a plastic card and a pickup window. The card carries an insurer's name, sometimes an employer's name, sometimes the name of a government program. The window carries a pharmacist in a white coat. The public argument about drug costs is usually staged as a duel between those two faces: manufacturers who set high list prices and coverage that feels stingy at the window. The missing character is the administrator, who turns a doctor's order into a paid claim before the pharmacist even finishes counting. Pharmacy benefit managers were not designed to be famous. In the 1980s and 1990s, as American employers pushed medical coverage toward managed care, someone had to decide which pharmacy sat inside a network, which molecules sat on a preferred list, and what a claim was worth in the 2 seconds between a scanned barcode and a cash drawer. Paper could not survive that clock. Electronic adjudication could. The PBM became the switch between the benefit and the bottle. The economic logic was ordinary, and that is why it spread. A self-insured employer with 10,000 workers cannot staff a department to haggle over every blood pressure tablet.
A purchaser covering millions of lives can, in principle, extract a better unit price than a single counter. Group buying is older than this industry. Hospitals do it with sutures. Airlines do it with fuel. The novelty is not purchasing power. The novelty is that the buyer of the benefit is not the person swallowing the tablet, and the negotiator is often not the insurer whose logo prints on the card. By 2006, Medicare Part D opened an outpatient drug benefit for older Americans, and the administrator was no longer a back-office vendor. Public money now ran through private formulary design. Commercial employers copied the architecture because it was already the architecture. Medicaid managed care contracts copied it again. A model built to process claims had become the model that shaped access. The card still looked like insurance. The decision rights had moved. What the public still misses is the rebate as a separate river. A manufacturer can concede money that never appears as a lower sticker on the package. The concession is retrospective. It is tied to volume, to formulary rank, sometimes to the exclusion of a rival product. The health plan may receive a share. The PBM may retain a share under the management contract. The patient whose copay was calculated from a list price may receive nothing from that river. The arrangement can be written into a legal document. It is still easy to lose on a kitchen table. In 2024, the Government Accountability Office published a report on selected states' regulation of pharmacy benefit managers. The report did not need a scandal to describe the job. PBMs administer prescription drug benefits. They negotiate rebates. They affect drug pricing. They use pharmacy reimbursement arrangements, including spread pricing, in which the amount billed to a client plan and the amount paid to a pharmacy are not required to be the same number. That language is administrative. It is also the reason legislatures started writing statutes. The machinery had become hard to audit from outside the contract. States did not suddenly fall in love with claim switch software. Independent pharmacies said reimbursement was arriving below the cost of acquiring the drug. Plan sponsors asked why published list prices kept climbing while rebate programs were marketed as savings.
Patients hit prior authorization, step therapy, and specialty pharmacy lock-ins without knowing which legal entity had written the rule. Legislatures answered with licensing, with audit rights, with limits on particular reimbursement methods, with demands that certain spreads be disclosed or forbidden. The GAO mapped a patchwork. A patchwork is not a single national verdict, and a statute on paper is not the same as a patient seeing the net price. The blind spot sits in the generation that built this. The decisive figure is often not the number at the register. It is the net after later money moves. Public debate still arrives at the register because the register is visible. Those ledgers can lower a plan's net spending without ever teaching the person at the window how the concession was split. The next scene is not history. Follow the 5 signatures.
A prescription is a medical act. It is also a stack of signatures. First signature, the plan sponsor. An employer, a commercial insurer, a Medicare Advantage organization, a Medicaid managed care plan. The sponsor's incentive is not a morality play. It is a per-member number. Drug spend that explodes will show up in premiums, in bids, in the cost of keeping a workforce covered. The sponsor hires a PBM to make that number move down, or at least stop humiliating the medical trend. The sponsor also has members who complain. A formulary that blocks a popular drug creates call center noise. The sponsor lives between a spreadsheet and a complaint. Second signature, the PBM. Revenue can arrive as an administrative fee per claim, as a share of manufacturer rebates, as spread between plan billing and pharmacy payment, as margin inside an affiliated pharmacy, as fees for specialty management. Those streams do not have to be evil to collide. A rebate calculated as a percentage of list price grows when list price grows. A spread grows when the two sides of a claim are farther apart. An affiliated pharmacy grows when fills are steered. The PBM's professional story is cost control.
The PBM's income statement can be a function of the very gaps it is hired to compress. Do not invent a cartoon villain. A tight pass-through contract can send almost every rebate to the sponsor. A loose contract can leave money on the administrator side of the glass. The document governs. Most patients never see the document. Third signature, the manufacturer. Access is the oxygen. A drug that is not preferred on a large formulary loses volume, even if the clinical trial was clean. Rebate offers become the price of admission. Exclude a rival, gain a rank, pay a concession. If competitors are playing the same game, list prices can rise while net prices, after rebate, follow a different line. The manufacturer is not confused about this. The manufacturer is playing the game that the PBM built. Fourth signature, the pharmacy. An independent shop, a large chain, a mail-order warehouse, a specialty pharmacy that handles fragile biologics. Reimbursement arrives as a formula, sometimes after the fact, sometimes with fees clawed back when a performance metric is missed. If the PBM also owns a pharmacy, the independent shop is negotiating with a customer who is also a competitor.
Acquisition cost does not care about that conflict. Inventory still has to be paid. Fifth signature, the patient. The patient has a diagnosis and a copay and a limited tolerance for paperwork. Prior authorization can delay a start. Step therapy can force a cheaper molecule first. A specialty network can force a shipment from a warehouse the patient never chose. The patient's incentive is brutally simple. Get the medicine, do not go broke, do not wait. A formulary committee excludes a drug. A patient on that drug has to switch or appeal. A 90-day mail mamble moves refills out of a local pharmacy. A specialty lock-in moves a fill into an affiliated channel. Each move reallocates margin among the 5 signatures.
A claim hits the switch. The pharmacy has already typed the identifier. The patient is still at the counter, waiting to learn whether the benefit will pay. In those 2 seconds, a file answers. Preferred, non-preferred, excluded. Quantity limit. Prior authorization required. Specialty network only. The answer feels like medicine. It is a contract executing at retail speed. The formulary is the first lever. A PBM, acting for a plan, ranks drugs into tiers and can exclude a product entirely. Manufacturers answer with rebates and fees tied to that rank. The negotiation is not a polite discount sticker. It is a contest for volume. A higher list price can support a larger rebate and still leave the manufacturer with a target net. The plan may celebrate the rebate as savings against the list. The patient's copay, if it is tied to list or to a tier copay that ignores the later concession, may not move. The same dollar can be savings on one ledger and opacity on another. Watch the incentive without inventing a verdict. If an administrator's compensation includes a cut of the rebate, a larger rebate is not only a better deal for the client, it is a better input for the administrator. If the contract is pure pass-through, that particular collision fades and other collisions remain. Staff at the Federal Trade Commission, in an interim report released in July 2024, write into this tension with qualified language. They analyze concentration, vertical integration, formulary influence, and effects on pharmacies. They discuss incentives and potential effects. The document is staff work, interim. It is not a final commission ruling that assigns a measured injury to each household. Keep the qualifier, and the blade is still sharp. Vertical integration is the second lever, and it is running now. The same corporate family can include a health insurer, a PBM, a mail-order pharmacy, and a specialty pharmacy. The patient experiences this as convenience. One card, one shipment, one nurse on a phone line. The independent pharmacy experiences it as a customer who also owns the rival warehouse. Steering can be written as a network rule. A fill for a high-cost biologic can be required to travel through the affiliated specialty channel. The plan can argue that specialty pharmacies prevent waste and abandoned doses.
The affiliated pharmacy can earn a margin the independent shop will never see. Both statements can be true on the same day. Spread is the third lever, already named in the public record as a reimbursement arrangement, now watched in the present tense as a live gap. A client plan is billed one number. A pharmacy is paid a smaller number. The difference can remain with the administrator. Some states have moved to forbid or disclose that gap, especially where Medicaid managed care money is involved, because public programs discovered they were the client being billed the higher number. Other contracts still live in private commercial paper. The gap does not need to exist in every claim to matter. It needs to exist in enough claims on enough expensive molecules to become a business line. Pharmacies answer in the present. Some close, some accept the network because leaving the network means losing the foot traffic attached to the card. Reimbursement formulas can be recoded after the fill. Performance fees can be assessed later. A shop can believe it was paid, then discover it was paid less. The FTC staff report describes pharmacy effects as part of the concentration story.
Description is not the same as a courtroom judgment. The description is still a map of shops that buy inventory at one price and are reimbursed at another. Plans answer too. Some large employers demand pass-through pricing, rebate transparency, and fiduciary language. Some keep traditional spread contracts because the quoted administrative fee looks smaller when the real compensation hides in the gap. Procurement is a theater of the visible fee. The invisible streams are where the weird economics live. Manufacturers answer by feeding the gate. A rebate wall can make a clinically similar rival expensive to prefer. Biosimilars can be kept in the waiting room if the incumbent's concession is larger. Patients experience this as a denial that sounds clinical. The denial may be clinical. It may also be arithmetic. And then the two public documents sit on the same table, unable to collapse into one moral. On one side, the cost control function. Administrators exist because plans cannot adjudicate millions of claims by hand, cannot build a 50-state pharmacy network from a human resources office, cannot bargain molecule by molecule without a specialist. That function is real.
On the other side, concentration and conflict. When a handful of administrators sit across from every major manufacturer and also own pharmacies, the specialist is no longer only an agent. The specialist is a market. Formulary rank becomes a scarce good. Affiliated volume becomes a profit center. Pharmacy reimbursement becomes a transfer price inside a family, not only a payment to a stranger. Staff analysis flags the incentives that follow from that structure. Potential effects are not the same as measured injury in every household. They are the reason the structure will not stop being a political object. The pharmacist watches the screen. Approved with a copay. Or rejected, call the doctor. Or approved, but only if the bottle ships from a warehouse 2 states away. The patient signs. The claim closes. Somewhere else, a rebate is accrued that the signature never mentions. Somewhere else, a spread may sit in a field the pharmacy cannot read. Somewhere else, an affiliated channel books a margin. No single one of those fields has to be a fraud for the chain to be strange. The strangeness is that cost control and self-dealing can share a timestamp. States keep writing statutes.
Federal staff keep writing reports. Contracts keep getting signed in rooms without patients. The wound is the timestamp.
There is a quieter law underneath the contracts. An intermediary is supposed to be a thinner market, less chaos, more comparison. A specialist who sees every claim should find the waste a scattered buyer cannot find. That is the respectable theory, and it is not a fiction. Group purchasing, electronic adjudication, a pharmacy network that actually answers the phone, these are production, not theater. A messy retail drug market without an administrator would still have high prices. It would also have chaos. Chaos is not the same thing as fairness, and removing a middle layer does not magically print a lower number on a bottle. The weirdness begins when the specialist is paid like a market. In most agency stories, the client pays a fee and the agent hunts a lower price. The fee and the price point in opposite directions. In this chain, some of the compensation can point in the same direction as the fog. A concession that is large because the list is large. A gap that is wide because the 2 sides of a claim are not required to match. A warehouse that fills the prescription the network just made mandatory. None of those streams need a disguise.
They need a definition of savings that lives on the client's net and not on the patient's counter, not on the pharmacy's invoice, not on the manufacturer's list. Economics has language for this, and it does not require a villain. Split incentives, transfer prices inside a firm, an auction for formulary rank that treats access as a scarce good, a principal who cannot see the agent's other principal. The plan thinks it hired a bargainer. The manufacturer thinks it hired a gate. The pharmacy thinks it met a payer. The patient thinks the card is the plan. All 4 thoughts can be locally true. The global picture is a payment chain with more than one customer for the same act of administration. That is why the structure stays politically hot, even when a particular contract is clean. Transparency statutes try to make the later money visible. Pass-through clauses try to force the agent's dollar to follow the client's dollar. Fiduciary language tries to name a duty. Each tool is a patch on a measurement problem. If savings are defined as rebate against list, list will be invited to grow. If savings are defined as net to plan, the patient's copay can be left outside the definition.
If savings are defined as reimbursement to pharmacy, the affiliated warehouse can still book a margin the definition never captured. The interesting object is the definition. Picture a ledger with 2 clocks. One clock closes at the counter in seconds with a copay. The other clock closes at the end of a quarter with a concession, a true-up, a fee. The United States built a drug benefit that lets those clocks disagree, then hired a specialist to live between them. Sometimes the specialist forces them closer. Sometimes the specialist's own revenue is the disagreement, and then the clocks refuse each other. The open question is not whether administrators should vanish. Ask it slowly. If a plan's net can fall while a patient's out-of-pocket does not, and a pharmacy's reimbursement can fall while an affiliated channel's margin holds, whose cost was the benefit manager hired to control?